Good morning, PTO Nice Daily Show. How are you? I am Dr. Lindsay Huey, lead faculty for extremity management, and forgive the raspy voice, but it is a sign of coming off of an excellent weekend of extremity management held at Onward Denver. Thanks to Lauren for hosting us. What a beautiful facility that was, and what an amazing weekend of participants that were engaged. We had a lot of laughs and a lot of load. Today, I want to dive into a topic that's near and dear to my heart. And so the title of this is FAI, Let's Fight Back with Love. And what I mean by that is let's fight back with that love language of load. But before I get into that, just want to say that really all of our live courses for the year have ended out besides a couple private. So really look at our ptonice.com, check out our 2023 courses. A host of them are coming up in January, and we would love to have you, especially at Extremity Management. I will be at Onward Atlanta in January, so I'd love to have you there. That'll kind of be our first offering for Extremity. But check out ptonice.com and plan your 2022 because these courses are filling up very quickly. We're already starting to schedule to 2023, which is wild. So let's dive right into the topic of FAI. So before I get into kind of what I believe is the way we can fight back and really load up these humans well is kind of let's identify the problem that I see in treating patients with FAI. So unfortunately, we've seen an incredible rise in over-medicalization and surgery for this population. So in 2004 to 2009, we saw a 365% increase in the US in surgical rates, and then another 250% in 2007 to 2011. So I'm sure at some point you've seen someone on your caseload with FAI, so that femoral acetabular impingement, and whether it was a pincer or a cam or a mix, these humans are getting told that they should have surgery. And so the big problem with that is that in more recent studies, in the last couple years, we found that when you follow those who have FAI that didn't get surgery, managed conservative, and then you follow the ones that did get the surgery, so they got that arthroscopic surgery, their outcomes are the same at 2 years. The other thing is when we image MRI humans that have no pain, we actually see a big percentage of labral tears, up to 69% in an asymptomatic hip. What guides the surgeon to want to do a surgery? It's that image, right? And if our images are not reliable and valid, then we're basing a medical procedure on something that doesn't tell the whole story. And so what does tell the whole story? Well, it's that human in front of you, right? And it's their symptomatology, and it's their goals, and it's the ecosystem they bring as the human as well, right? And so I think physical therapists are best suited to really address and help FAI. And so let's fight back, right? What I mean by that is let's not allow over-medicalization to occur anymore. So let's have a good understanding of FAI and then attack the weaknesses. And so what does their human with FAI usually look like coming into your clinic? That's going to be a person that has groin pain or pinchy symptoms. It is often that more athletic human, anywhere from the age from 20 to 45. They're a dancer, or they're a weightlifter, or they're a hockey player, or some kind of athlete that involves a lot of deep squatting. And then they start to get kind of debilitating pinching, deep ache groin pain. It doesn't feel good. And so they come to you, and they're coming often because it's limiting their sport participation. And so we really need to appreciate how that affects ecosystem too, right? The stress level associated with not being able to participate in something that's important to you, and then also important to your team, right? Or your family. So other things that we'll kind of see in these humans when we think about what's the objective exam look like with someone with FAI Well, they're going to have a positive impingement test, so that fader test. They're going to have limitations in range of motion, passively, and it's going to be painful. The other thing is they actually are going to all have some surrounding soft tissue tenderness and weakness. And you often see this masked as tightness, so like the iliopsoas in particular. Glute max, glute med will be really weak here. And so what's interesting about that is that when you come to an extremity management course, or those that are just coming off of a course this year, you know that we have two buckets. So it's extra-articular and then intra-articular as our main buckets. And so the person with FAI tends to fit in both buckets, not distinctly in one or the other. And so it it requires an approach that will address joint limitations, dampen irritability through joint mobilization, but then also treating the soft tissue structures around that. And so I want to show you kind of my ideal treatment plan for these humans. But before I dive into that, I do want to let you know what the evidence says about us treating FAI, because I already mentioned kind of that disconnect in how MRI isn't always representative of patient symptoms and how we are jumping to surgery too quickly as a society. And so what we know about PT as of 2020, when we look at the American Journal of Sports Medicine, Hoyt et al. Did a systematic review. Now this was 5 RCTs, so keep that in mind. But when they looked at the evidence as a whole and what helps FAI, here's what was found. Core strength is something that's helpful. When they compared active versus like passive treatments, active was always better. So like passive stretching, active would be superior to that. And then supervised physio versus unsupervised. So giving someone just a HEP versus they're in the clinic with you, you're watching their movement pattern and you're giving them feedback. So those 3 things. What I'll say is when you look into those articles though, it's very non-specific about the details of what is core strength, what is active versus passive, what is supervised physio. And these programs were anywhere from like 6 to 12 weeks. Some of the words or verbiage alluded to for like core strength were plank, bird dog, pelvic tilts, some hip abductor strengthening, or bridging. And you might sense a sassy tone right now because I don't think any of those are good enough in this population. This is an active population that wants to load their joints and they need to load into deep flexion, right? Those exercises aren't going to cut it. And then you'll also see advice in those articles about avoiding squatting, avoiding sitting, avoiding athletic activities that cause growing pain. The humans from 20 to 45 years old, those humans do not want to avoid activity, right? It's our job to help them enjoy their world and still take part in activity. So we have to have strategies to do so. And so it's not okay to just say avoid activity. Yes, maybe we change it for a time, but we can do better here. And so if I've kind of referenced extremity management a couple times, and for those of you that have already been, you'll kind of know this, but how we attack the hip is we will want to dampen irritability, right? And that either comes through joint mobilization if there's some intra-articular stuff going on. And then we're going to take a lot of time to also address ecosystem, right? Think about the human. I mentioned this a little bit earlier. They're an athlete. If they're in primetime season, maybe they've gotten to the finals, like there might be some stressors there. You have to think about their diet. How's their hydration? Are they getting enough protein for the in-season demands? Addressing just overall fatigue levels. A lot of these patients are female, so thinking about, is REDS on board? Are they eating enough? And so if you don't address that right away, you will not dampen irritability. So you could tell them to avoid all activities, but if you don't address that ecosystem consideration, there's not going to be change. So you have to address the ecosystem. And I will use language like, let's reduce the amount of sitting for a time, right? If someone is an athlete, but then they're sitting all day at their desk, right? Think college athlete, maybe it's letting them know that taking breaks every 30 minutes to get out of that chair, to get blood flow, to decrease that compression. of the femur and the acetabulum, or that sensation of like pressure or pinching. And then giving them ways to just dampen irritability themselves. So if traction is the thing that helped in the clinic, teaching them how to do some self-traction, some easing techniques. The other thing that goes along with dampening irritability is, I mentioned that there's two buckets, right? Intra-articular and extra-articular. Some of the times there's extra-articular, pretty much all the time. The extra-articular structures like TFL, rectus femoris, they are very hypertonic. And so they need things like soft tissue massage, dry needling, cupping to dampen irritability and tone. And so you can teach, not only treat those things in the clinic, but then teach the patient how to follow up with ways to dampen that irritability, whether it's soft tissue massage. A lot of those athletes have Theraguns, something that just gets that irritability down. And then teaching them kind of how to monitor symptoms and what are acceptable symptoms. And I think the 24-hour monitoring rule that we use a lot with our tendinopathy patients is super appropriate with these humans, because we want to load up that cuff around the hip. And so we are going to load all the muscles around. And so we approach that in extremity management as anterior, lateral, posterior, medial. So I'm hitting every angle of that hip that is involved for the human, or that blipped on exam that had that tender disc palpation and or weakness. And so if they know that 24-hour kind of pain monitor, they know what's an acceptable kind of response to symptoms. Now, some of you are like, but Lindsay, this is a joint issue. Well, how can we use like a tendon? Well, I'm going to argue and say that we can really dampen irritability in that joint structure and reduce it if we really build up musculature around that. And if we treat it like this, if we treat it almost like it's a tendinopathy, whatever part of the hip's involved, we'll use our same tendinopathy principles, right? When someone comes to you with high irritability, we'll do more of an isometric dosage to those muscles that are weak around the hip. So think iliopsoas, glute med, glute max. And then we can build and do heavy slow. And then when they're accepting that and doing well with that, then we can do compressive release, like things like jumping, running, do things that are more intense once they handle that load, and then move on from there. And so this is that charge to fight back with our love language of ice, which is load, right? How do we make our humans super resilient and impactful in their own world, feeling equipped and resilient to move in their world pain-free? It's really getting them strong around that area that's bothering them. And so I would like to show you kind of a specific sample plan of what I would do for someone with high irritability with FAI, and then someone with lower irritability, and how I'll use our principles of tendinopathy to help that human. And this is definitely kind of a cursory overview of FAI, and we dive a little bit deeper into the course, so I'd love to have you there. But I want to show you this kind of to end out this morning. So in the beginning, I really love using Rehab imams, and because of Mitch teaching us about the Rehab imam, pretty much everyone, if you're ICE faculty, is using some kind of Rehab imam with their humans. But in the beginning, when there's high irritability on board, not only am I having a conversation about how's your sleep, how's your diet, how's your protein, so ecosystem effects, but I'm going to get some kind of cardio on board. So what you'll see here is me addressing that piece, and then the typical muscles involved in FAI. So the first one would be a psoas march. And the psoas march would ideally be banded. If there's high irritability on board, I will make it a more isometric dose. But psoas march for a minute. And we're really going after good pelvic control, not falling into that anterior pelvic tilt, not falling into that posterior pelvic tilt, but kind of that neutral, which is kind of hard for these humans because they're either stuck in one or the other. And then minute 2, echo bike as hard as you can, super intense. And then lastly, addressing posterior and lateral chain, a banded hip thrust. So I want them getting a bar on their hip. I want this to be loaded, but also band around knees so they're engaging lateral hip, glute med, and working at like a 70%. So working kind of a hypertrophy dose to build up cross-sectional area of those glutes. And in this way, it's non-irritating, and we're also working on hips extension and keeping that nice neutral pelvis, not falling into anterior pelvic tilt, but not falling in to complete posterior pelvic tilt. Words are hard apparently right now. I need another sip of coffee. So here is for that lower irritability, 5 rounds. 15-minute rehab imam, a go-to for that higher irritability presentation with FAI. If someone with lower irritability, I want to make it harder, right? So if they're coming to you in a stage where it's not as pinchy, ADLs aren't really as limited, but they still, when they load up that squat, they still get that pinchy pain. I'm going to want to have a weighted psoas march. So them moving past midline off the table. So one leg, they're kind of at the edge of if they're at a CrossFit gym, a box, or the edge of their bed. If they're in your clinic, edge of table. A minute of weighted psoas march. And how I'll break this up is they usually need to do both sides. There's usually one symptomatic hip, so I might start with part practice just that hip, but then ideally I'll do 30 seconds right leg, 30 seconds left leg, but putting that kettlebell right on the toe and alternating load. That second minute, front squats. Front squats allow a little bit more upright posture, and starting to load that up to that 85% 1 rep max, because I want to build capacity in the glutes and midline, right? I told you what, PT is that core strengthening, glute strengthening, and supervised PT. So you're checking all these buckets, but in a very fitness forward way. That third and last is step ups. And step ups with a kettlebell on the opposite side. And so 5 right leg, 5 left leg. You'll do 5 rounds of this. Why step ups? When we look at the literature and the evidence, when you are doing an 18-inch step up or above, that's when there's greatest glute max firing. The glute max needs to be built up in these humans. What else is amazing about the step up? It works on lumbopelvic control and stability, and it works on the whole kinematic chain from hip, knee, ankle, foot. And so this would kind of be an ideal rehab imam for that person with lower irritability. And you'll see kind of a mix of strength dosages on here and endurance as well. Lots more reps when we're thinking about that psoas march and kind of retraining that lumbopelvic unit. I would love to hear what you're doing with your patients with FAI and what you have seen works and what you think about kind of my 2 proposed rehab imams. Note that this is not based, this is based on a bunch of patients I've seen with FAI. I'm obviously making a program that is specific to the human in front of me, that meets their goals. But please email me at lindsayhuey at gmail.com if you have any questions. I appreciate your attention this morning. Let's fight back and treat our humans with FAI with the love language of load. Have a happy Tuesday. It was great to be with you all on this Clinical Tuesday. Bye.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.